Hello, welcome to this week's tutorial. I would first start off with a quiz. This quiz would allow you to test yourself on what you have learned last week, which is basically the application of the egg diagram to figure out eye movements. After that, I'll give the answer and then we'll do a quick recap of what we have learned to date. Next week, I will use the same egg diagram to explain how central and peripheral nystagmus comes about. Thank you. For this quiz, I will give you 3 minutes, each one of you to do it alone. And for that is this picture, not a video for you to look at. And again, many of you will come up with spontaneous answers, which again, just like your maths teachers, I'll get very irritated when you give spontaneous answers because it's not foundational, it is memory based. You come up with an answer that maybe guesswork. Okay, we prefer you to do the workings. Okay, just like maths, if you do your workings and you show me your steps carefully, then I know you have understood the concepts clearly, and therefore you will be able to get it right, not only now, but subsequently. Your system is always there for you to get it right all the time, not something memory-based that's just pattern recognition, which is very superficial and not foundational knowledge. So don't jump to the gun by just looking at the woman's face and come up with a spot diagnosis. Work foundationally. How do you do that? Well, basically use the egg formula. The first diagram, she's looking at the red pin. Okay, draw the eggs and figure out which one should be. She's looking to the left, right? Sorry, looking to the right, right? So the arrow to the right and arrow to the right. All the others should be black, but these two arrows should be red. Okay. Similarly, you look at the bottom picture. Now she's looking to the left. And then you decide which eye is not moving and you draw the red arrow. Then you go back to the first diagram, connect up the nerves and the nuclei and the medial longitudinal fasciculus, everything. Then come back to the bottom, connect it up, and then you try to superimpose and see what you get. Okay, I'm going to give you 3 minutes to work, each one of you to draw on a piece of paper on your own. And then in about, now it's about 2.5 minutes, I will be able to give you the answer. This is to give you confidence that you can work out what looks like a complex problem, and also to stop people. Some of you may have jumped to the gun and make a spot diagnosis, which is good if you are doing neurology now, but later on, when you're not doing neurology, you forget all the spot diagnosis. Okay, another more minute. Okay, so as I said before, you will break it down into steps, right? So the first diagram, she's looking to the right. Then if you draw the arrows, obviously both arrows will be red. Okay, for both arrows to be red, the lesion can only be in the 6 nucleus. Okay, of course it can be in the frontal eye field also, but we'll keep it simple. Draw it here. Of course it can be in the frontal eye field. For this purpose of this diagram, I'm just going to keep it here first. Okay, draw the first part. Okay, then we go back to this diagram again. Now she's looking to the left. Now when she's looking to the left, okay, this eye is not moving, this eye is moving very well. Okay, so you will draw, this is red, this is black. So for this to be red and this to be black, the lesion can be a number of things. Okay, but one of them is medial longitudinal fasciculus. Okay, so if you think about this lesion, it's in the left side of the pons. This lesion is in the left side of the pons. Sorry, right side of the pons. This lesion is also in the right side of the pons. So if you were to superimpose, okay, you realize that
this is probably the most parsimonious explanation because a small lesion in the medial longitudinal fasciculus, a small lesion in the medial longitudinal fasciculus that extends slightly more laterally and touches the sixth nucleus, okay, can actually easily explain all these three arrows to be red. Okay, of course, like I said before, individually there are other explanations. Okay, but this is the most parsimonious explanation because you put a dot here, you put a dot here, these two put together is the most elegant explanation. So a small lesion in the medial longitudinal fasciculus on the right side that extends and involves the sixth nucleus on the right side. Both are on the same side of the brain stem, same part of the brain stem, both are in the pons. Both have similar vascular supply. So anatomically, pathophysiologically, it's very feasible to have a small lesion here. You don't have to think about one lesion here, another lesion here. Remember, in Occam's razor, you need to find one lesion to explain everything. A small lesion here can explain 3 out of the 4 eye movements of normal. Okay, so this is what this lady's pathology is. Now, this, because it is 3 out of 4 eye movements affected, this is known eponymously, or rather syndromically, it's known as the 1.5 eye syndrome. Many of you look at the face like this and make spot diagnosis, which is not foundational. I'd rather not you make the diagnosis. And as I said, it's not important diagnosis. What is important is using this egg diagram to work it out, so that use this kind of formula can then be also used for other more complex eye movement abnormalities. Okay, but this is one complex eye movement abnormality that you were able to work out without pattern recognition, but by using the egg formula, systematically drawing one of the drawing the diagram and drawing where the lesion could be. Okay. Okay. Any questions? Okay, if there are no questions, I'm going to go do a quick summary so that we don't lose you, because some of you may find the pace a little bit fast. Okay, so basically we start off with testing the eye movements, right, in the cardinal planes. So using the egg diagram to decide which arrow is not working. And then you connect up the arrow to the relevant nerves and the nuclei. But you must remember, it's not just the nerve that could be abnormal, it could be a muscle problem. And if it's individual muscles, you must always think about a localized muscle pathology, like fibrosis of the muscle that occurs in, for example, thyroid eye disease, or it could be a localized neuromuscular junction problem affecting that particular muscle. After you have ruled that out, then you have to think about the nerve. And because we are dealing with nerve, whether it's the sixth cranial nerve or the third cranial nerve, you use the 4 rules of the cranial nerve and you work it out. Okay, that's straightforward. Then you come to another eye movement abnormality like this. Again, intuitively, you can come up with various diagnoses, but foundationally, it's better for you to draw the diagram and realize that this patient's a red arrow would be on the adducting eye, and that will be giving rise to a number of diagnoses, and you have to consider a number of diagnoses: restriction of one muscle, neuromuscular junction problem, third nerve problem, or a problem between the two nuclei, the so-called internuclear ophthalmoplegia. Here, after you have ruled out a localized restrictive problem, neuromuscular junction problem, cranial nerve third problem, then the presence of this abducting nystagmus in the other eye, which is due to overstimulation of the intact nerve, tells you that this is most likely due to medial longitudinal fascicular lesion, due to internuclear ophthalmoplegia. Okay. So then we gave a more complex case, but again, you could break it up because again, you went step by step. One step is look to the right. Then the next step is look to the left. Okay. Then you put both of them together. Again, could be a muscle, neuromuscular junction, nerve, or because these two medial longitudinal fasciculars are so next to each other, it could be a bilateral INO. And the presence of the intact convergence, which is a different eye movement, because it convergence, unlike saccadic movement, requires visual stimulus and is coming directly into the third nerve, not through the medial longitudinal fascicular. Medial longitudinal fascicular lesion in the pons would spare convergence. So the sparing of the convergence in her confirms that it cannot be a localized muscle, cannot be neuromuscular junction, cannot be third nerve. It can only be a medial longitudinal fasciculus in the pons that is only catching the fibers coming in through the MLF without catching the convergent fibers. Okay. Then we talked about gaze. Okay, lateral gaze. And we realized that lateral gaze is controlled by the 6 nucleus. So the 6 nerve nucleus has got greater responsibilities than the nerve itself. It controls ipsilateral gaze. Okay, but not only does it control on its own reflexly, but volitional movements, the command is sent to the 6 nucleus by the cross frontal eye fields. And this is the part that you need to memorize. It is not ipsilateral frontal eye field, it's cross frontal eye field. So anybody who has got a difficulty looking to the left, therefore, could have a lesion in the 6 nucleus, lateral gaze center, or the frontal eye field. And to differentiate that, I give you 3 steps. Look for the side of hemiplegia of the limbs, look for the type of facial weakness. And finally, we use this to explain how to connect the 8th nerve to this network of fibers. And we realize that using the vestibular dance, by just turning your head left and right without using memory, you would be able to work out that you need to connect the contralateral 6 nucleus to the ipsilateral, or other way around, the ipsilateral 6 nucleus to the contralateral 8th nerve, because the movement, the turbulence is maximum in the contralateral 8th nerve vestibular system, then has the semicircular canals, and that has to be transmitted to the ipsilateral 6 nucleus to effect abduction of the eye, so that without even thinking about it, you can voluntarily foveate as your heads are turning left and right. That is the vestibular ocular reflex, or the Doll's response. So knowing that, you are able to use that as an additional tool to differentiate between a frontal eye field lesion where the vestibular ocular reflex is not affected, okay, and differentiate it from the 6 nucleus lesion where the vestibular ocular reflex will be affected. Right. Okay. And then to prove to you that the egg diagram is very useful, even when it comes to a complex eye movement disorder, and the steps, and the key point here is not actually the formula itself, but the understanding that everything in science you have to break it down in steps. So first step, egg diagram to the right, second diagram, egg diagram to the left. And then you put these two together. Of course, there are other ways of explaining, but the most parsimonious explanation, the most elegant or the simplest explanation would be a lesion, a small lesion affecting contiguous structures in the ipsilateral pons, causing movements, affecting movements, all horizontal eye movements except for contralateral abduction. So that's why it's known as a 1.5 syndrome. Okay, so that's the summary.
As I mentioned at the beginning, I hope to see you next week when we will be using the egg diagram to explain how central and peripheral nystagmus comes about. See you. Goodbye.